Thanks, Andy, and thank you for having us back. For me, it's a pleasure to be back in South Australia. I did my first 6 months in general practice 30 years ago in Port Lincoln at the Investigator Clinic, and looking back, it was actually really formative and a great health system. And I particularly remember the incredible support on the phone and with the aeroplanes arriving to remove children with meningitis and major car accidents that as a young doctor I was looking after. So I think you've got a great health system already, and hopefully we can do a little bit to make it a little bit better. So I'm going to show you what it is we're talking about. Now, it's a bit squeezed up. It actually doesn't quite look the same on a normal computer. This is the Canterbury Community Health Pathways. So that is more or less what you guys are going to get, but we also have a hospital view for junior doctors, an allied health view, and a patient view. So 4 views of the same pathway. Some important things to see before I forget to say it is the send feedback button that produces a lot of conversations. We take it very seriously when people send feedback, and we get lots of feedback from the users, which means that we can connect people way out of the middle of the health system to senior people to have a discussion, and people can feel real involvement in improving their health system, because if they send feedback they actually get a senior response. Now, on the front page we use it for news, so thrilling news in Canterbury is poisonous shellfish in Akaroa Harbour, and the dermatologists are all off on maternity leave. So that's probably good. Now, the table of contents is written out, very recognisable to most people in health, as a series of medical groupings and then medical departments. So I thought we would have a look at a respiratory pathway for no particularly good reason. Also on the front here we have the Health Info is our patient information website, so trying to get patients to be given good quality patient information rather than old photocopied things by their general practice teams and others, and also to have the same patient information handed out, because if you think of acute asthma, patients go to a pharmacist and they get one brochure that says use 2 puffs of their blue inhaler. They go to the GP and they get told to use 6, and they look on certain guidelines, they get told to use 10 or 12. So the patients who tend to do nothing and turn up at the emergency department. So having consistent patient information is very useful. We put all our telephone numbers on here. It's a password protected site, so it's put people in closer contact with each other. Like I'm sure you have, we have a lot of existing clinical information that we put on the front. And this is a link to the hospital view and a New Zealand formulary, which I was pleased to hear you're doing a South Australian formulary, which sounds good. So, chronic cough. So a common general practice problem, one of the earliest pathways linked to covers people with a persistent cough for 8 weeks. There's also a chronic cough in children pathway. Related topics, reflux asthma and rhinosinusitis. A bit of background about chronic cough that is in a drop box because people aren't going to want it most of the time, because this is targeted at general practice teams, nurses and doctors and others who have patients in front of them. So it's used in consultations, and so you've got to be able to find the information you require really easily in the same place in 800 different clinical pathways. So it's all written with controlled language in the same layout and structure. So in South Australia you have influence, or you have control over the clinical content, the reliability of it, but the words and the format are managed centrally because it's all controlled language done by technical writers, which is a breed of person that you've probably not met before, and you've got two over there, not too scary, Mary and Melissa. So then underneath got some red flags, so the things that you really don't want to muck up as a GP and miss these causes of chronic cough, and that do get forgotten. So they're not necessarily all the red flags for chronic cough, but they're the things that have and do get missed. So we don't want more than a few on each pathway, because people are only going to glance at them as they look for something else. Then some basic assessment, because when we wrote this pathway with a respiratory physician, he pointed out that if GPs thought about asthma, reflux, snotty noses and ACE inhibitors, he'd only need to see about 10% of people that he was referred with chronic cough. So that's the focus of this pathway, is to make sure that general practice teams do a thorough assessment of those conditions. Also reminding people about sleep apnea, what investigations to do, and then practice points are things that tend to get done not as well as they could be, and GPs tend to be impatient with chronic cough and refer people without red flags or major risk factors quite quickly, whereas actually if they do trials of treatment, it may be some months before they actually need to refer people without red flags and other problems for a respiratory opinion. So just by doing this, we have markedly reduced our referrals for chronic cough to our respiratory department. And then other management to use, and then in the request section, if you do find you've reached the point where a general practice team thinks that a specialist opinion would be useful, how to get it. So advice, so we manage a lot of people without bringing them into the hospital from hundreds of kilometres away. We manage them by written and phone advice, and our cardiology department now manages half its referrals remotely without actually seeing the patients. We've done surveys of GPs, specialists and patients, and a very high level of satisfaction with that as a service. If a respiratory assessment is required, it goes to a page called a non-acute respiratory assessment, which in your setting is slightly muddled because you call acute what we call non-acute, but we'll sort that out. Well, you have an acute sector that I think is what, anyway, these are the non-urgent respiratory assessments. And so we have one main respiratory department at Christchurch Hospital, but further down we've got Ashburton Hospital and private, and in some areas there'll be 10 or 12 or 15 hospitals listed down there that all have specialist respiratory services, and then we list which patients they want to see in which order, so that the patients with the greatest need and ability to benefit are seen first, and those that can be managed in other ways are managed accordingly. And then down the bottom, if I just go back, so that's the request section. And then down the bottom we have clinical resources, so that when I realise that my knowledge of a topic is actually dates back to Paul Lincoln days, I can go and read